Okay, so any questions on any of the previous material we've covered thus far? All right. So we're going to be talking more about kinetics. We're talking about absorption, distribution, metabolism, and elimination. So again, some of this beyond just what the definitions we mentioned were. So again, we mentioned the pharmacokinetics. That is what the body is doing to the drug, right? So how it's going to be distributed in the body, how it gets absorbed, how it gets metabolized, and then eventually excreted from the body. So we're going to go into more detail on that. We're going to look at some concepts related to these kinetics, including things like loading doses. Anyone heard that term loading dose before? Anyone know what that is? We'll talk about that later, but basically we'll see that it's like giving a really big dose of a drug up front, and then you give smaller doses afterwards, and we'll look at why that is. Right? We'll look at some examples of that. We'll talk about steady state drug levels, and then we'll talk about how that relates back to toxicity as well. Okay. All right. So we're going to look at drug distribution, metabolism. We'll talk about volume distribution, how we can interpret that, how it's getting distributed throughout the body. We'll also look at some of the major pathways for drug metabolism. We'll look at some of the factors that will play into that as well. And we'll look at the kinetics of drug absorption, talk about the different mechanisms by which drugs get absorbed, look at how disease states can be affecting this, and then we'll look at the elimination. Do you want to think of what organ is primarily used to eliminate drugs? Yeah, kidneys. Yeah, kidneys is going to be a big one. The liver maybe is actually a site for elimination as well, though. So actually, we're not wrong on that one. So we'll get there. Okay. So again, kinetics is going to be from the time that you give a drug. Give the dose. We're going to see that the liberation of the substance, whether it be in a tablet form or something like that, or if it's bound to some other kind of carrier molecule, that liberation, how it gets freed, how it gets absorbed through usually the GI tract, or if it's through the skin or the lungs, whatever it happens to be. And then we're going to talk about this free drug that you're going to have in that central compartment. Okay, free drug is physiologically active drug once it gets to its receptor site. You're going to find that some drug is going to be bound up by serum proteins. You guys know if any serum proteins might bind drugs? Yeah, albumin is going to be a big one of the major ones we're going to talk about there. You're going to find that when drugs are bound to albumin, they're not physiologically active, right? They can't interact with their normal receptors to cause an effect. So that's going to be one of the things we'll talk about. You're going to see that some portion of the drug is going to be able to have an equilibrium and distribute out to the therapeutic site of action, whether it be the brain, the heart, wherever it happens to be. Some drug may be bound to the tissue. And again, once it's bound to the tissue, it may not necessarily have the ability to interact with those receptors. That also be inactive. And also there could be some unwanted side of action. So we'll talk about how that can lead to some toxicity. And then finally, they'll have the excretion metabolism of and this biotransformation is just kind of a fancy term for metabolism. You'll get these metabolites. They'll be excreted most often through the kidneys, but we'll talk about some other places that gets eliminated as well. Okay, so absorption will be the first thing on the list. So looking at absorption, so it's permeation. It's going to be a term used for this movement of drug through barriers. And there's a lot of barriers that will impede a drug's ability to be absorbed, whether it be an intestinal wall, whether it be a capillary wall. The blood-brain barrier is a really important one to keep things out of the brain. And a lot of drugs may be able to be absorbed through simple diffusion, this kind of aqueous diffusion. And simply, this is a passive process, meaning it doesn't require any energy for it to occur. And you're going to see that things are going to be driven from an area of high concentration to areas of low concentration. I'm not sure why that went out. Right, so things are going to be going along its gradient, high concentration to low concentration. Kind of in tandem with that, you're going to see this lipid diffusion is really important. Here's an example of lipid diffusion. This is a lipid bilayer that you're going to see on capillary walls. You'll see that with all types of cells. This is basically the cell membrane that a lot of drugs are going to have to cross through. And we're going to look at lipophilicity and how well it gets absorbed, or how well it gets solubilized in lipids, and that's going to determine how well this is going to be able to cross. So we're going to see things that have a high hydrophilicity, or things that are very water soluble, have a really tough time crossing these lipid bilayers. Things that are very lipophilic, or things that like to be dissolved in lipids, they're going to be able to cross very easily. Okay, so that's going to be a major determinant of how well drugs get absorbed. But basically, we're going to see that a lot of drugs are either going to be weak acids or weak bases. And so the pH of the solution that they're in is going to affect the charge of the atom, and that's going to affect how well it's going to get absorbed. Okay, we're going to go in more detail on this, but basically things that have a charge on them are going to be harder to cross lipid bilayers. Things with no charge are going to have an easier time crossing. We'll look at some of the reasons why that is. You can also have some other means of getting drugs across. A lot of times drugs may be lipophilic, but they may be very, very large molecules. That makes it very difficult for them to cross these membranes. And so in some cases you may have carrier-mediated diffusion of certain substances, meaning that you'd have a particular transporter that would be able to cause the molecule to cross the barrier without actually having to go through the lipids themselves. Okay, so good examples of this would be something like glucose. Like glucose is a very good example of that, where glucose is not able to cross into a cell by itself, but with the aid of things like insulin, it's able to move glucose transporters onto the cell surface that can then internalize those glucose molecules, and then you can use that for energy to make ATP. Okay, so it's a good example of carrier-mediated diffusion here. In a lot of cases, you're going to see that these can still go along their concentration gradient from high concentration to low concentration. That's still going to be a passive process requiring no energy. In some other cases, though, and you can see an example here where you have this ATP being utilized, that high-energy phosphate bond is being utilized in order to cause an active transport of a substance here. So in these cases, you may actually see that this is going from areas of low concentration and then going to areas of high concentration. So in some cases, you may see backwards kind of flow, and that's why it requires energy to push things against the concentration gradient. So again, aqueous diffusion is going to occur with the larger aqueous compartments of the body, so especially like interstitial fluid between cells and things like that. It can happen through these aqueous pores, especially like the endothelial linings of like the blood vessels. So kind of that space between the blood and the extravascular space that will allow for some aqueous diffusion of certain substances to cross there. And this is really governed by what we call Ficks Law, and this is going to be very pertinent to several types of drug absorption as we look forward. So basically, and I'm not going to make you calculate anything like this on the test, but it's really important to understand the concepts behind Ficks Law and understand how this could affect drug diffusion. Okay, so basically, Ficks Law is primarily concerned with aqueous diffusion and passive diffusion, right? So no energy being used here to carry molecules down to concentration gradient from high to low concentration. Okay, the ultimate thing we're looking for here, the amount of drug that's going to cross, is called flux, and that's going to be based on these several parameters here. So one being the concentration. The higher concentration, that's C1. C2 is going to be the lower concentration that the drug is going to be moving to, right? So having a bigger difference here is going to cause more flux, right? So the smaller C2 is, the larger C1 is, the more flux you have. Make sense? Okay. And then you're going to look at the area with which the molecule has to cross over, right? So increased surface area is going to allow for better absorption. Increased permeability coefficient, or basically how soluble the molecule is going to help to increase that flux. And then you're going to notice here on this denominator you have thickness here. And why do you think thickness is on the denominator? So you think it would be easier for a molecule to cross a really thin membrane or a very thick membrane? Thin, right? So that's why you have thickness being kind of inversely proportional to the flux here. So the thicker the barrier that the drug has to cross over, the less flux you're going to have. Very thin membranes are going to have an easier time crossing over. That's why you see, like, especially with like neonates or small infants, how developed do you think their skin is? It's not really that well developed. It's pretty thin, in fact. And so then in those patients, you may actually see pretty good absorption of drug through the transdermal route, especially when you don't even mean to. There are some cases where there's some parents who had given birth to a child. And basically, one of the things they would do for some of these infants is they would put lotion on them to keep them from drying out, especially if they're in the NICU and they're kind of exposed to open air. And for some of the patients, they were actually doing urine drug screens on the child to see if the mother had any kind of maternal drug use, right? And so all of a sudden, these children started popping up positive for THC. You guys know where THC comes from? Marijuana, right? So THC comes from marijuana. So they were like, well, this baby is showing positive for THC in the urine, so this obviously must mean the parents are, mom was, smoking the reefer. We're taking your kid away. Okay. Well, then they came to find out, okay, well, there's too many kids that are testing positive here. What the heck's going on? They went back and they actually found that the lotion they had, something was being absorbed through the skin of the baby, and it cross-reacted with that assay and showed up positive for THC. Okay, so again, kids will have very easy absorption of certain substances across the skin because that membrane is much, much thinner. Okay, so again, once they figure that out, they're like, okay, you can probably have your kids back again, because the moms would test negative for THC, but the kids would be positive, and so they were like, what the heck's going on here? This doesn't make sense. Going back, and then they could find a cause for it. Okay. So anyway, so thickness is going to be inversely proportional to the flux here. Thinner membrane, better flux. So this helps us to quantify these relationships for aqueous diffusion. So again, with larger concentration gradients, you're going to have faster diffusion, better absorption. Drug absorption is going to happen faster from organs with a large surface area. So think about things like the large intestine versus things like small absorbing areas like the stomach. Places where you have large brush borders and things like that really increase the surface area are going to have an easier time absorbing than things that have very kind of minimal amount of surface area. Okay, so that's one example. mentioned drug absorption is going to happen much easier through thin membranes. So like the lungs is a really good example of a very vascular thin membrane that drugs can cross with relative ease, as compared to something like an adult skin would have kind of a thick epidermis, and it's much more difficult for those molecules to cross. And basically, this is the body's way to try to establish a steady state for the drug. And we'll talk about what that is, but essentially steady state is going to be that the amount of drug I'm putting into the system is equal to the amount of drug leaving the system. Okay, it's an equilibrium that we're going to be reaching here. And so based on these different parameters, and this is like really important for like transdermal drug absorption, that you want to get to a steady state level that's high enough to cause therapeutic effect, but not too high, because what happens if the levels are too high? Toxicity, adverse drug reactions, right? We don't want that to happen. So we want to make sure our steady state is right in the right limit for our patients. Okay, so a good kind of showing you a pictorial example of Ficks Law in action. So again, the surface area, the bigger this is, the more flux you're going to have. The easier this has, the easier ability for this to cross the membrane, the more flux you're going to have. So that's that partition coefficient, and the higher the concentration gradient here. Thinner membrane, more flux. So a lot of the same things will apply to lipid diffusion. It just has to do with how lipophilic or how lipid soluble the molecules are going to be. But again, these provide pretty significant barriers to absorption, very difficult for a lot of molecules to cross if they are not very lipophilic. But you're going to find that the lipophilicity of a drug, or how well it gets absorbed through these lipid membranes, is going to be dictated based on the pH of the substance. Thank you. The pH of the solution that the drug is in, and also the pKa of the actual molecule. So we're going to go a little bit over. You guys ever heard of the Henderson-Hasselbalch equation? Anyone have like nightmares of that from chemistry? Yep, we're going to go over it again here and see how this relates back to drugs. Again, pH and drug pK are going to be super, super important here to determine how well those drugs get absorbed. We'll talk about weak acids and weak bases and how that relates back to that Henderson-Hasselbalch equation. So looking at this, we'll talk about pKa. This is essentially going to be the acid dissociation constant. Basically what this means is that if every weak base and weak acid is going to have a pKa, basically what that means is if you take a drug, say with a pKa of 7, and you put it into a solution which is 7, and 7 is considered to be acidic or basic? Neutral, absolutely. So basically if the pKa equals the pH, that means you're going to have 50% of the molecules are going to be protonated, meaning they picked up a hydrogen ion, and 50% are going to be unprotonated, meaning they do not have a hydrogen ion attached to them, right? When you get to more acidic mediums, what happens to the hydrogen ion concentration? It's going to go up, right? Because as you get more acidic, as you get to lower pH numbers, you're going to get higher hydrogen ion concentrations. As you get more basic, you're going to lose those hydrogen ions, okay? So we'll look at why that's important in a minute. But the way that we're going to have the nomenclature for these substances, for a weak acid, you're going to find that when it's protonated, and it has a hydrogen ion attached to it, it's going to be in the uncharged state, right? Because normally when it doesn't have a hydrogen ion attached to it, it's going to be in that negative charged state, right? So there's going to be weak acids here. Conversely, if you're looking at weak bases, when weak bases have that hydrogen ion attached to it, now it actually does have a charge, right? It's picking up an extra hydrogen. Now it's going to be more positive. You're going to find this is going to have a harder time crossing those membranes. Whereas if you had a base that was lacking that proton, you would find it to be uncharged. And so we're going to look at how that can affect the drug absorption in just a minute. But basically the thing to remember is like dissolves like. If you put a weak acid into an acidic medium, it's going to be more likely to be in the uncharged state. If you put a weak base into a basic medium, it's more likely to be in the uncharged state. Okay? So like dissolves like. All right. So looking at this, you can see the weak acid. Notice that there's going to be some degree of flux here, and that's based on the pKa of the drug and also on the pH of the solution. Part of it's going to be in this protonated state but uncharged state. Part of it's going to be in the unprotonated but charged state. You're going to notice when it's trying to cross that lipid membrane, having that negative charge on there makes it very difficult for it to cross. It's just going to bounce right off of that because it's not very lipophilic. It's much more water soluble. On the other hand, you're going to have here this uncharged this protonated weak acid. It's going to have a very easy time crossing over because it's going to be more lipophilic, and then it can dissociate again into depending on whatever the pH of the solution is on this side of things. Okay. The opposite is going to be true for weak bases. As bases pick up hydrogen ions, so this would be like in a more acidic medium, you're going to find it's going to have a charge on it, have a harder time being absorbed versus the base by itself. And more basic medium is going to be unprotonated and uncharged, and it's going to have a very easy time crossing over. Okay, we'll look at some clinical examples of why this actually matters. I'm not just using it to torture you guys. Okay, it actually does come up time to time. So again, if you're looking at the Henderson-Hasselbalch equation, it basically will give you what that ratio of protonated to unprotonated species is going to be by looking at the pH of the solution. It's going to be equal to the pKa plus the log of the ratio from the non-protonated species to the protonated species. Okay. Basically, when you look at this for weak acids, you're going to see that the log is going to be the A minus over the HA, that protonated species, and it would be the opposite of that for the base. Okay. This in this case would be uncharged. Here it's going to have that proton there. This is going to be in the charged state. Okay. So when the pH is equal to the pKa, it's going to be a 50-50 split, meaning you're going to have half of it is going to be protonated, half is going to be unprotonated. As you shift things one direction or the other, you're going to find that you're going to have a shift in that ratio to either more of the protonated species or more of the unprotonated species, depending on which direction you're going. So if you go more acidic, more of it's going to be protonated. If you go more basic side, less of it's going to be protonated there. And so you're going to notice that here the acid is going to be in the negative charged state, the base is going to be in the uncharged state. And on this side, the more acidic mediums, when the acid is going to be in a uncharged state versus the base being in a charged state. Okay. All right. So what this means is for an acidic solution, this means that weak acids are going to be protonated, they're going to be uncharged, and going to be lipid soluble. This means you can have things like weak acids like aspirin. Everyone's familiar with aspirin, right? It's going to be in the more protonated state when it's in a more acidic medium. So in the GI tract, where do you think it gets most acidic? In the stomach, right? pH is like 2 in the stomach, right? So if you're looking at aspirin in the stomach, it's going to have a very easy time being absorbed because more of it's going to be in that lipid soluble kind of state, right? Versus if you're looking at something like a weak base, they're going to be protonated. It's going to be in a charged lipid insoluble state. So something like morphine. Morphine is a weak base. It's going to be in a protonated state, which means in the stomach it would have very poor lipid solubility. It would not be able to get absorbed very well. Okay. Once things leave the stomach, they go into where? They go into the duodenum next, and then how does the pH shift when you get there? It's going to go up, yeah. It's going to either be neutral to more basic, and you're going to see the kind of the flip happen there. So you're going to see that some drugs get absorbed much better from acidic environments like the stomach. The majority of drugs are probably going to be more easily absorbed in places like the small intestine. Okay, so we'll see how that can be affecting drug absorption in just a few minutes. Okay, so examples of some weak acids and weak bases. I'm not going to make you remember which one's which on a test, but the concepts here are what's important, right? So has anyone ever heard of the drug phenobarbital? Patients may say peanut butter balls, but that's not what they're actually referring to. This is a popular, it's an older drug, but it's an anti-seizure drug, which you may see some patients on. Some animals might actually be on it for seizures. These are all examples of weak acids you would see. Notice how the pKa can range pretty greatly there, with something like aspirin having a pKa of 3.5, meaning that if you put it into an acidic solution of pH of 3.5, 50% would be protonated, 50% would be unprotonated. Versus something like pentobarb, you put it into a solution at pH of 8.1, you're going to be a 50-50 split there. Okay, and so based on the solution that the drug is in, whether it be in the small intestine, whether it be in the colon, whether it be in the stomach, that can affect how it's going to be absorbed. Okay, on the flip side, you can have weak bases. Who knew cocaine was an actual drug that we use in hospitals? It is true. We don't use it very often, but every once in a while we may see, we used to have cocaine over at the children's hospital. You're like, why the heck would you carry cocaine? But it's a very good drug for certain surgeries. You can use it for like ENT surgeries. But other drugs like morphine, so you can see how, again, their pKs can range pretty greatly depending on just the molecule itself and where that pK is going to be sitting at. Okay. So other things that can help us to absorb drugs, we mentioned special carriers. So for instance, you can have special substances that will be carried by these transporters. So for instance, looking at certain things will carry amino acids. So specifically to get amino acids into the blood-brain barrier, you're going to have special transporters that can move those over. In the renal tubules, you're going to find you have ones that are specifically meant for weak acids. They're important for regulating how well either drugs get secreted or reabsorbed from the renal tubule, which is important for elimination. So in a little bit. Again, these are usually going to be for molecules that are too large to diffuse passively through the membrane. Okay, so there's some molecules that are just so big they're never going to be able to get across that membrane on its own. They need those transporters to actually move them across. The big thing here to note is that this is not governed by Ficks Law, and it's going to be capacity limited. So that means that if you have a high enough amount of drug, you can saturate all of those transporters, and you can limit how much drug is going to be able to be transported per unit of time. Okay. A lot of times you're going to find these require energy. These are going to be active processes that are happening here. And in some cases, they may go against that concentration gradient. So you may see things moving from areas of low concentration to high concentration, which is certainly not the norm. Ficks Law, you're going to find that it's not capacity limited. It's going to be able to, as you keep increasing that concentration of drug on the one side, you're going to keep getting more flux, basically until you can't change that capacity anymore, right? So, and again, not energy dependent. You're going to find it only goes from high to low concentrations. Okay. So a good example of a carrier protein, so we have this multi-drug resistance type, or MDR1 transporter. Another good name for this is P-glycoprotein. This is actually known as an efflux transporter. So this actually prevents things from being absorbed from a particular type of membrane. Okay, so if something were to get across the membrane, this protein will be able to spit it back out into the outside environment. Okay, this can be found in places like the brain. Like usually you want to keep bad toxins and stuff out of the brain, so this is a good protein that can help with that. Find in places like the GI tract as well. And so this is a really big target for certain drug interactions, right? So for instance, if I were to have this drug or this molecule being active normally, and I were to absorb a drug from the GI tract and then this protein spit it back out, that's going to maintain drug levels at a certain level. Okay, if I inhibit that, what do you think happens to the drug levels then? It should go up or down. So I'm not effluxing as much, I'm not sending as much back out to the GI tract. Drug levels should go up, yeah. So we've actually seen some problems where, you guys I'm sure have heard of, like, don't take this medication with grapefruit juice, right? So this is an important drug interaction where certain drugs called statins, they are a drug we use to lower cholesterol, one of the mainstays of therapy for cholesterol-lowering medications. If you combine these two together, you can get increased levels of statins, an increased risk of liver damage, increased risk of rhabdomyolysis. Are you guys familiar with that term? What is that?
Muscle waste?
Yeah, basically muscle breakdown. Yeah, so massive muscle breakdown, and basically it clogs up your kidneys, get renal failure. It's no good. So that's one of the big interactions we worry about. We have to warn our patients about to make sure, especially older patients, they love their grapefruit juice. Their taste buds aren't really working as well as they used to, and so they want something to really hit those taste buds. But this can cause very, very dangerous interactions with some of their medications. Okay, you can find some of these transporters. There's several different kind of flavors of transporters you can see there. Again, you don't have to memorize where each of these are going to be located at, but just know, if a drug gets absorbed through a particular transporter and that gets inhibited, know how that's going to affect the drug levels, versus if it's an efflux pump and it's trying to keep drugs out of a system, what is that going to do to levels if I were to inhibit that? Okay, those are kind of important things to know, especially when you're thinking about things like cancer drugs. Like sometimes for certain cancer drugs, cancerous cells will actually generate resistance to some of these drugs, and some of it's by actually overexpressing these proteins to try to kick those cancer drugs back out of the cell as quickly as possible, so that way it makes them less effective. Okay, so there's actually some very important clinical cases where this comes up more often than you might think. Other ways that molecules can be absorbed, one way is going to be endocytosis. Are you guys familiar with that term? What is that? Yeah, basically kind of like cell eating, or we'll talk about phagocytosis and pinocytosis. Basically, it's like kind of like the cell giving whatever molecule kind of the hug of death. Basically kind of hugs it really high and sucks it in. This is really good for molecules that are either too large or they're too lipid insoluble or otherwise impermeant to the cell. They can't get in any other way. Sometimes this endocytosis can be a good way to get that in. And so some examples of this would be vitamin B12. It's a water-soluble vitamin. It's really important for things like production of DNA. If we don't have that, getting certain anemias that can happen because your red blood cells don't produce correctly. They can only be absorbed when you have intrinsic factor bind to them in the GI tract. Once intrinsic factor and B12 are stuck together, then the GI cells get that signal, and they can go do the endocytosis and get them into the cells at that point. Okay. Another iron with transferrin. Iron is not able to be absorbed very easily through the GI tract unless it has that transferrin molecule that can help to engage that endocytosis process. You also have exocytosis, which is going to be the opposite effect, where basically the cell is going to be releasing some sort of vesicle of some sort of molecules, whatever it happens to be. Good examples of this would be for releasing things like calcium into the bloodstream. Basically, the cell would have a vesicle they can basically just send out to the cell surface, open up, and then send out whatever molecules those are. Enzymes for the pancreatic cells are really important here. You guys think of any enzymes that are involved with the pancreas? Lipase, amylase, protease, yes, all the stuff that we use to digest our food, a lot of it comes from the pancreas, and so it's really important that we have that exocytosis process. Even hormones from the endocrine glands are important here as well. So if you have things like cortisol or aldosterone and things like that, usually get released by exocytosis. Just show you an example, basically extracellular fluid here. Endocytosis is going to be basically the incorporation of these molecules into a vesicle versus the exocytosis being the release of the molecules from the vesicle. Okay, so that's how drugs get into the system. How do we then distribute them throughout the body? Well, one of the big terms we're going to look at is going to be volume of distribution. It's probably a term you're not going to have a firm grasp on until you get like some practice with it. So, think it through some examples when you're kind of studying this on your own. I'll show you some examples when we go through here. But basically, it's kind of a theoretical number. It doesn't actually mean a whole lot when we're looking at it. But what it is this apparent volume of that the drug would have to occupy in order to give you the serum concentration that you're achieving in the body. Okay, so basically what that means is I inject a drug into your system. Okay, so I inject 100 milligrams. Okay, based on that, and we talked about volume distribution. Sometimes you can have a large volume distribution. Sometimes you have low volume distribution. We'll go into details on what that means. But it basically is saying like how far out into the tissues does that drug go? Does a lot of it like to distribute very far out into like the adipocytes, or does a lot of it like to stay in the central circulation right there in the bloodstream? And the thing that we can use to correlate that with is going to be the concentration that I measure from the blood. Okay, so I inject the drug into you. The drug can circulate around. Some of it will distribute out, depending on the certain characteristics. And I can measure a serum sample from you. And based on that concentration, I can say, okay, this drug is very far distributed out, has a very large volume distribution versus a very small volume distribution, which means a lot of the drug is still there in the blood, and I can measure it right there. Okay, so I'll show you some examples of what that looks like in just a minute. So basically the way we can look at this is that volume distribution is usually measured in liters, is going to be equal to the amount of drug in the body, so that's the dose that I give you, over the concentration I get from the plasma. Okay, so I measure the amount of drug in the plasma, and basically I divide those out, and I'll be able to get this volume distribution. Okay, very large numbers here mean that basically the concentration of the plasma is very low, so if the drug is not in the blood when I measure it, where else could it be? Out in the tissues, right? So that means that this number would be very low, and that would having a small denominator would cause my VD to go up, right? So I mean I have a very large volume distribution. Versus if I gave you 100 milligrams of that drug IV, and I were to measure in the bloodstream, and this number is very high, this will lower my denominator, which means my volume distribution is low, which means a lot of it's staying right there in the bloodstream. Okay. So an example of this would be if I gave you 25 milligrams and I were to measure the plasma concentration, end up being 5 milligrams per liter. By dividing that out, I can see like, okay, well that drug has a volume distribution of 5 liters. Okay, so just as simple as that. Okay, basically a high volume distribution generally indicates that drug is more lipophilic, and that it likes to distribute very far out into the tissues. So again, if you think about like going back to THC, right? We mentioned that's the psychoactive component of marijuana. What's the kind of the thing like you hear about like drug testing THC? How long can you test it for? Long time, short time? Everyone's like, I have no idea how long it is. No. So THC has one of those kind of reputations, like, oh, you can test it for months after the last time you used it, right? There's some caveats to that, but in general, what that means is that THC is very, very lipophilic. It likes to go into the fat tissue, and it likes to be stored there over a long time. So if you have someone who smokes marijuana every single day in a very high dose, a lot of that will be distributed out into the fat tissue, and then they can be leaching that back into the bloodstream for several weeks after the last time they smoked, and then they can still detect it in the urine. Okay, so THC would have a very large volume distribution versus something that is going to just maintain the bloodstream, and then once I clear it, then it's gone. Okay, so, and you kind of think like, how big of a tank am I really having to put this drug into in order to equal that concentration? So say for instance, I have 2 different drugs. One is going to be drug A, which is hydrophilic, which means not very lipid soluble, likes to be dissolved in water. And this one's going to have a low volume distribution, which means it likes to be in the central circulation, likes to stay in the blood, doesn't like to partition out to the surrounding tissues. Okay. Drug B, on the other hand, is lipophilic, loves to be in the tissues, right? It's going to be distributing out, especially like adipocytes and things like that, it's going to love that. So let's say I were to give 50 milligrams of each drug to 2 identical twins, right? So the twins have no differences between them, so you can assume all their kinetics are the same. If I were to give the same dose of the drug to the 2 different twins, you would end up seeing that the concentration of drug A would be 10 milligrams per liter, and then for drug B, I got 0.5 milligrams per liter. Okay, so when I actually do that math, if I did the volume distribution equals 50 divided by that serum concentration, which in this case was 10, got 5 liters, versus here on the more lipophilic drug, 50 divided by 0.5, and I'm getting 100 liters. Okay, so it shows you the drug likes to distribute out much farther out into the tissues, where because of that lipophilicity, right? So it can be more lipid soluble, it can cross those barriers much more easily. Okay. So you'll oftentimes see that when you are comparing volume distribution to different drugs, you'll notice it's going to be expressed in terms of liter per kilogram. Once I know the weight of the patient that I'm going to be dosing, then I can multiply this liters per kilogram times their weight. Kilograms cancel out, and then I know what that patient's particular volume distribution is. By keeping it with these units allows me to be able to say, okay, well, doesn't matter if I'm giving it to you or you or you or you, doesn't matter. It's always going to have the same volume distribution, and these are usually going to be based on population kinetics. So this is kind of the average, right? They tested a ton of people who got it, during those kind of initial clinical trials. They were doing studies like this to see what the levels were, and so they said, okay, well, this is the average, right? And of course, are all your patients going to be average? No, you're going to find there's going to be differences here between patients, but in general, most of them should fall within this. So looking at something like heparin, you guys know what heparin's used for? It's an anticoagulant. Yeah, your body even produces some of its own inactivates clotting factors. You notice here it has basically a very small volume distribution, 0.05 to 0.1 liters per kilogram. In general, anything less than 1 liter per kilogram is considered to have a small volume distribution. Anything bigger than 1 liter per kilogram is considered to have a large volume distribution. Okay. So that 1 liter per kilogram is kind of the easy cutoff to remember. So that would have a very low volume distribution. And so where do you think the drug would like to partition to? In the blood or out in the tissues? Likes to stay in the blood. And that's important because where's heparin going to be working at? In the blood, right? I don't want it out in my stomach fat. Like I want to be there in the blood vessels, keeping the clot from happening, right in my lungs or wherever it happens to be. So that's a good thing, right? Looking at other drugs, you can have drugs that have very high volume distribution. So things like digoxin. Digoxin is an antiarrhythmic that we use sometimes for patients with AFib, or if they have congestive heart failure, we're giving this drug. This is a very, very high volume distribution, so 2 to 5 liters per kilogram. So that would make you think, okay, all that drug likes to partition out very far out into the tissues. This is actually an interesting example where that's not really the case. This one is really just that digoxin loves to bind to myocardial tissue. So actually all that drug is binding to the myocytes, but because of the fact that you can't measure it in the blood, that still gives you the same kind of phenomenon of having a high volume distribution. Okay, so there will be some examples, some exceptions to the rule, but in general, anything with a high volume distribution is going to be partitioning out more into the tissues, is generally going to be more lipophilic. Okay, everyone with me so far? All right. All right. So let's say we can. The reason why this is important, and there's going to be certain drugs, and especially drugs that have a narrow therapeutic index. And you guys remember that term? What does that mean? Yeah, there's a narrow safe zone, right, where you can dose the drug where a patient is therapeutic, but they don't cause toxicity. This is super important that we know volumes of distribution and we can apply them to our patients, because this will help us to make sure we're achieving the right type of levels. Too low, maybe that infection keeps spreading, right? If it's too high, patient has ototoxicity in the ear, or they have nephrotoxicity in the kidneys. We don't want that to happen. So using these kind of kinetic variables can help us out with this. So for instance, knowing the weight of the patient, and knowing the volume of distribution, and then knowing the dose of the drug, we can actually estimate what the plasma concentration that patient would actually have. Okay, so say for instance we had a 70-kilo man, we gave him 100 milligrams of this drug that has a volume of distributions of 0.6 liters per kilo. And so is this high or low volume distribution? Yeah, it's considered to be low, so a lot of it likes to stay within the bloodstream. Okay, so what would his estimated plasma concentration be? Well, basically doing the simple math, you can say, okay, well, if I did 70 kilograms times that 0.6 liters per kilo, that will tell me what this particular patient's volume distribution is. Okay, right? The kilograms are going to cancel out, and then now you have 42 liters would be the answer there. Okay, I know that I gave 100 milligrams. That's my initial dose, and then I want to figure out. I want to solve for the C0. C0 being my initial concentration in the plasma that I'm going to measure. So what I can do, basically flip that around. So I have C0 equals 100 milligrams divided by 42 liters, and that equals 2.38 milligrams per liter. Okay. Milligrams per liter is also oftentimes on labs, like you'll see micrograms per ml. It's going to be the same thing, right? Because it's just by a factor of 1,000 on the numerator and the denominator, same numbers here. But 2.38 milligrams per liter. Okay. So I was able to estimate based on the size of the patient, based on the dose I gave him, based on the volume of distribution, what that plasma level I would get. So I would say like either, okay, well, that's perfect. That's the right kind of dose I should give that patient. Or maybe that's too high. Maybe I should only give him 50 milligrams. Or maybe I need to bump the dose and give him 200 milligrams instead. Based on that, based on the estimates, I can figure out how I should dose this patient. Okay. I will have very simple calculations for this, so you shouldn't need a calculator, maybe some scratch paper. Yeah, so basically this is the main equation to understand is that VD equals dose over C0, and by flipping those variables, you're able to figure out, kind of, you can solve for the third one if you have the other two. Okay, that was a very good one to remember. Hey guys, it looks like this slide must have been hidden for whatever reason. I'll say it was a glitch in the system, but I just want to talk about this slide real quick. Basically, volume distribution can be affected by several different factors, including disease states and other types of interactions and whatnot. So for instance, volume distribution may actually be decreased in some cases. One circumstance would be things like plasma protein binding. Essentially, if more of the drug is being bound up by serum proteins like albumin, it tends to hold that drug in the central circulation, which ends up dropping your volume distribution, right? Because it's less extensively distributed out to the tissues. Another thing would be dehydration. So if you have like a lack of body water, it tends to concentrate. You want to hold things into fluid into the intravascular system in order to maintain blood pressure. That tends to lower your volume distribution, especially of more hydrophilic medications. Things that can increase volume distribution would be something like renal failure, where you end up having fluid retention unless you get kind of hypervolemic and you have excess body fluid. That can end up leading to a larger volume distribution, again, especially due to hydrophilic medications. And the same thing can happen with liver failure. Basically, they have altered body fluid. They can have issues where not only are they holding on to a ton of fluid, similar to the renal failure case, but they can actually have problems where they're not producing enough serum protein. So for instance, it might be low on albumin, and again, there's less proteins to bind the drug. More of it's going to be free to distribute out to the tissues, unless your volume distribution will be increased. All right, so then looking at metabolism, let's see how these drugs actually get broken down. All right, essentially metabolism is this mechanism that's going to terminate or alter the biologic activity of a substance. The main function here is that we want to make drugs typically more water soluble. Okay, the more water soluble they're going to be, the more likely they are to be excreted in the kidneys. Okay, because again, looking at the filtrate in the kidneys is primarily water. We want the drug to be very soluble in the water, so that way it can get spit out in the urine, and then the drug's gone, right? So in general, metabolism is trying to make the drugs more water soluble or just in a state ready to be excreted. Okay, so metabolism is going to happen before the actual excretion occurs. Normally, you're going to find that these metabolic reactions are going to be either deactivating, so they may lead to a drug that is originally active to be inactivated. So I'm going to be kind of detoxifying, leading to less pharmacologically active products, right? And you'll find in some cases that's not always going to be the case. Sometimes you can actually have active metabolites. We'll talk about those in a minute, though. Okay, so you guys remember that term prodrug? It's an example of a drug that we would give in the inactive state and does not actually become active until it gets metabolized. So I mentioned that lisdexamfetamine, that Vyvanse, which is an ADHD drug. When you give that, or if you were to say crush that up and snort it, you really wouldn't get a whole lot of effect out of that because it's inactive. But if I give it orally, it's going to, a large proportion of it hits the liver, gets metabolized to the active form, and then I have my ADHD effects, right? So I get more focused, or I'm able to sit down and for a prolonged period of time and focus on something. Okay. Another good examples of things like ACE inhibitors. So these are really good antihypertensives. You're going to see these used quite a bit for like your diabetic patients and patients with CHF and all kinds of patients. Basically, we give these in the inactive form, and then the liver is going to metabolize over to the active form here. So enalapril turns into enalaprilat. That's the active form that actually can lower blood pressure. Okay. Codeine, we mentioned before, gets metabolized over to morphine. We mentioned that variability that can happen there, or some people are going to have a lot of that enzyme to make a lot of morphine. Some people are not going to have a lot of that enzyme, can't make a ton of it. So that can affect the clinical efficacy of that morphine there. Okay. So metabolism primarily is going to occur within the liver. It's the main organ we're going to be concerned with, but you can also see some metabolism happening on the lungs, the GI tract, skin, the kidney. Some limited amount of metabolism can happen in all these different organs. Sometimes you can see enzymes in the liver can actually change a drug over to, basically they will turn them into metabolites. So if a drug gets metabolized, metabolites are formed in. So if we talk about that, that's what we're referring to. But again, the main goal here is to convert the xenobiotics into the more water-soluble form, getting ready for excretion. There are two main types of metabolic reactions. There's going to be phase 1 and phase 2 reactions. Phase 1 reactions are typically going to be introducing or uncovering some sort of polar functional group that allows the molecule to get ready for phase 2 reactions. Okay, so you're going to find that type of reactions we have here are going to be things like oxidation, reductions, hydrolysis. These can all be done to make a molecule either more water soluble and get it ready for excretion on its own, or get it ready for phase 2 reactions. Okay, so one of the things that people get tripped up on is that not every drug that undergoes phase 1 metabolism has to go to phase 2. Sometimes they only undergo phase 1. Some drugs only undergo phase 2. Okay, so again, it's not a predestined thing that everything goes through phase 1 and phase 2. Some of them can go through either one or both. But there's several different types of enzyme systems that are responsible for these phase 1 metabolisms, like things like esterases, which would destroy ester groups, and amidases and things like that. The primary one that we're going to be concerned with is cytochrome P450. Anyone ever heard of P450 before? You will have heard of it a lot after my class. It is a super important enzyme system. It is responsible for metabolizing the great majority of drugs we have available to us nowadays. Okay, so understanding the interactions you can have with this and how this system works is really integral to making sure you're going to be prescribing drugs safely. Okay. All right. Phase 2 reactions are typically we're going to either add or alter a molecule to also increase that water solubility. So usually you're adding on some sort of functional group onto the molecule that makes it more water soluble. So you can see things like conjugation, glucuronidation, sulfation, so either adding on a sulfate group, glucuronide group, something like that, in order to make it more water soluble and get it ready for elimination. So here you can see an example of things like some of these cofactors like NADH or NADPH can be utilized to help with this oxidative process here. But basically, you have a CYP enzyme that will cause metabolism to occur. You notice you can have these phase 1 metabolites that will happen here. Some things can just be excreted right after phase 1 metabolism. Some other things will end up going through phase 2 reactions. So this one here would be a glutathione conjugation. Basically, by adding on a glutathione group, you make the molecule more water soluble, and then can be excreted through the kidneys. Okay, so again, it can either go through both of them, can go through one or the other. I'll show you a good example of this in just a minute. Illustrates that. And this is the example. So acetaminophen, everyone's familiar with that? Everyone know the brand name for that one? Tylenol, there you go, yeah. So Tylenol is a really good example. It has several different metabolic pathways you can see here. So again, every drug may have multiple pathways. Drug may only have one type of pathway depending on the substance. But basically, you can have acetaminophen can be, you can see it predominantly will go through this glucuronide conjugation, where it adds on a glucuronide group to it, makes it more water soluble and able to be excreted through the kidneys. Some of it will go through the sulfation pathway. About a quarter to a third of it will go through the sulfation pathway. One thing we have happen, though, is that a very small proportion of it will actually go through the cytochrome P450 system. And we'll look at the different isoenzymes of cytochrome P450, but it goes through this one called 2E1. And essentially what you end up getting is this reactive intermediate called NAPK. NAPK is really, really dangerous. When you overdose on Tylenol, what's the main organ that takes a hit? The liver, right? And this is because this NAPK product is going to be overexpressed essentially, right? Because again, you'll notice that some of these metabolic pathways can be overwhelmed essentially. So if I run out of glucuronide to add on that Tylenol, and if I run out of sulfate groups to add on there, then all of it's going to end up going through this 2E1 pathway, right? So I can form a lot of this NAPK. Now your body may have some ability to detoxify stuff like that, and so in this case you would have a glutathione group that could be added on to here, so where again you would have a detoxified molecule that can be eliminated. But in those cases where we have overdose patients, they would end up depleting this as well, and so they just have a ton of NAPK around that can go and destroy the liver, hit the kidneys, cause all kinds of problems, right? So just note that it can go through multiple pathways. With these ones, it being adding on a glucuronide group or adding on a sulfate group, these would be phase 1 or 2 reactions. I'm adding on a group, phase 2 reactions, right? In this case with the cytochrome P450, because I'm oxidizing it, this would be a phase 1 reaction. But here, when I add on a glutathione group, now it's a phase 2 reaction, okay? So note in this case, these are just going through phase 2 reactions, but in this pathway, I have a phase 1 followed by phase 2, and that's finally detoxified, okay? So just to show you some of the different ways that drugs can end up being metabolized. Just some other examples of different type of metabolizing enzyme systems, but again, phase 1 is typically either making it more polar or causing a functional group to be uncovered that gets it ready for phase 2, and then phase 2 again is adding something onto the molecule. Okay. We also have other systems, things like alcohol and aldehyde dehydrogenase. These are really important for metabolism of what do you think? Let's write in the name. Ethanol, alcohol, absolutely. So you can find some other systems that are out there, but majority of things we'll talk about are going to be included in the phase 1 and phase 2 reactions. Okay. All right. we probably alluded to this first pass effect. This is going to be where when a drug gets absorbed through that intestine and then through the liver, through that portal system, you're going to find that there's some degree of metabolism that happens there. For some drugs, a ton of it will be metabolized, making it so that you almost get no bioavailability. Sometimes you're going to have very little being metabolized. So you have a very high volume or very high bioavailability in those cases. So basically, it's going to be that concentration of the drug gets reduced before it reaches that systemic circulation. So it's going to vary based on medications. A good example of this would be ethanol. So if I give ethanol via the oral route, right? If I have you take a shot, it's going to go through the GI tract, gets absorbed. Some degree of it gets metabolized through the liver, right? So not all that alcohol that I swallowed actually ends up in the system, right? What if I were to give it via a different route? Like, what are some other routes that I could give alcohol? You guys think of any? Hopefully none that you've tried. Per rectum? Absolutely, yeah. So if you guys ever heard like a vodka enema or like a beer enema, right? So people, again, these are usually young people who have too much time and not enough sense. They would administer, and in some cases, like young girls would actually put tampons, and they would do it intravaginally, or they take a tampon, soak in, apply it rectally, wherever they could stick it, basically. And what you find is those mucous membranes are very highly vascular, and you also bypass a significant amount of first pass effect, right? Because it's going to go to the systemic circulation before it really hits the liver at first. So now, even though it may be a dose of alcohol that you can handle orally, they're getting way more bang for their buck by these other routes. Deaths have occurred from that. So basically, respiratory depression, CNS depression, pass out and they stop breathing, they're dead, right? So there's been several cases of that, unfortunately. But different routes are going to have different amounts of bioavailability based on that first pass effect. Yes, ma'am.
Can you do it intravenously?
You can do alcohol intravenously, yeah, and so that would have almost 100% bioavailability because.
I've heard that in the hospital, so I
Yeah.
know patients that are going through withdrawal, like the alcoholics and the.
We don't do it for them so much. We have other drugs that we use to help with alcohol withdrawal. What we used to use it for was if someone ingested like radiator fluid or like windshield washer fluid. Those are actually really toxic alcohols. We could give IV alcohol to basically prevent the body from breaking those down because it likes to metabolize ethanol preferably over other alcohols. And so we give it to them to keep those liver enzymes busy, and then you could just pee out the other alcohols. Yeah. So we don't do that fortunately anymore because, again, oftentimes there's little kids that were getting into this stuff, and then you have to be like, okay, well, you get to treat your kid in the ICU, and we're going to make them drunk for like 2 or 3 days. Parents don't like that so much. Yeah. I think it'd be kind of funny, but that's my kid, so everyone's a little different. So sometimes IV alcohol could be used, but that would have very high bioavailability, very little first pass effect because, again, it's all going straight into the venous system, not really hitting the liver initially.
How long can you infuse? How long until you reverse
Long as
the effect of the original?
Yeah, so in those cases, you'd basically either use a dialysis machine, like an artificial kidney, to pull off those alcohols, or you just give it time for the kidneys to release them on their own. So you could have it like 3 or 5 days or something of IV alcohol you'd have to get. You could also just do it orally too, though. So we'd give those guys go down to ABC and grab some grain alcohol and just have them drink that instead. Whatever works, Yep. All right. Okay, so going back to that P450 system, this is involved in a ton of biosynthesis and catabolism reactions. It's going to be metabolizing a ton of drugs and different chemicals. So we're going to see that this is one of the primary enzyme systems you need to be familiar with when prescribing drugs. And it helps to determine how intense of an effect we may see based on how quickly it's metabolizing or not metabolizing a drug, and also the duration of action. Okay, so when you have P450 being overactive, what do you think that would do to the duration of action of a drug? Would it lengthen it or shorten it? It should shorten it, right? Because if I'm metabolizing more drug, it should be sticking around for less time. Okay, vice versa, if I were to inhibit those enzymes, then that would increase the duration of action of a drug. And those are super important reactions to remember, and we'll go into more details on those in just a little bit. But these are probably one of the top types of drug reactions you're going to run into, and I'm sure some of you guys have done the homework who run into a P450 interaction, or at least read about one maybe. You guys already blocked out that homework assignment. That's okay. It'll come back up again on the next one. Okay, so we've probably identified over 1,000 different individual enzymes here, and basically we have about 50 that are functionally active in humans that we're mainly concerned with, and you're going to have multiple forms of it. Okay, so you'll find different names we're going to have for these different isoenzymes or different forms of P450, and so each one gets encoded by a different gene, and that's why you can have genetic differences between patients. I mentioned for that CYP2D6 was the one that was responsible for metabolizing codeine to morphine. Found that especially African American patients were more likely to have increased amounts of that enzyme versus white patients who would have lower amounts of that enzyme, right? So that would actually be making less codeine out of it, or less morphine out of it, due to genetic differences. So this is a huge area for pharmacogenetics to try to figure out like who is going to be metabolizing these drugs well and who's not, because that could make a big difference in what type of side effects they may see. Okay. So when looking at a CYP enzyme, you're going to see that, say for instance, we have a name of a CYP, say CYP2D6. Okay, the CYP is just referring to the fact that it's a cytochrome P450. The 2 refers to the family of enzymes that it has. So basically, it's looking at the homology or how similar the amino acid structure is between the different enzymes. D would be here the subfamily, or so we're starting to see more homology here between the different enzymes. And then finally, 6 would be that individual sequence. Okay, so CYP2D6 would be the main enzyme we were talking about when converting codeine over to morphine. In that case, okay, we'll talk about other specific CYP enzymes as well as we move on. So just be able to draw this out on the test. That'll probably be about 20% of the grade. I'm just kidding. I just showed this to you just because it looks scary, and then also just to kind of show you that basically this is the oxidation that's actually happening here. You can see the P450 enzyme actually causing the oxidation. I'm sorry, here's a P450 actual enzyme where it's causing the oxidation. Eventually, you put the drug in here. You just have like a, whatever functional group with a hydrogen on the end there. Basically, through this oxidation pathway, the ultimate product you're going to get is this. And so having a hydroxyl group on the end there, does that make it more or less polar? More polar, right? So it's going to be more water soluble. It's going to be more likely to be excreted in the kidneys. Okay, so that's the ultimate end product we're looking for when we have CYP P450 enzyme interactions, or when we're having the actual metabolism. Okay. Again, don't memorize this list, but just here are some of the common ones you're going to run into, and notice all the different drugs we have that are involved here. CYP P450 is responsible for a ton of different drug metabolism, and you can notice here that sometimes you can have things that will induce CYP enzymes, and sometimes you have things that will inhibit CYP enzymes. So for instance, who was around any kind of barbecues or charcoal cooked foods over the weekend? No one? No one? No 4th of July parties? Wow, I guess you're studying for, yeah, okay. I know, my other students had a test this morning as well. They're, yeah, we're on the beach just with our textbooks opened up. I was like, well, there's worse places to study, I suppose. But yeah, so something like having those byproducts of that combustion of the charcoal can actually cause induction of those CYP enzymes. You'd have more enzyme present that can metabolize drug, and it would actually decrease the half-life of it. It actually cause it to be metabolized more quickly. Okay, you have things that will inhibit it. Usually these are drug-drug interactions that we're going to be most concerned with, causing inhibited metabolism, causing drugs to stick around for longer, and that can lead to certain amounts of toxicity there as well. Okay, so. And just to give you an example of showing you the different CYP enzymes here, notice here's also some other phase 1 reactions as well, like esterases and whatnot. Notice CYP3A4. This is the main Mama Jama CYP we're going to be concerned with. All right, CYP3A4 is the main one you hear most of the drug interactions about. Metabolize about 50% of the drugs here that go through the CYP enzyme system or through phase 1 reactions. Okay, so CYP3A4 is one of the big ones. Other ones you're going to run into, CYP2D6 is another pretty predominant one. Things like 2C9. Yeah, 2C9 is another really important one. So we can talk about things like warfarin, which is an important anticoagulant. So, and then looking at the phase 2 reactions, you'll notice these are going to be much more kind of evenly spread for the most part. But just again, CYP3A4, if you look at a CYP drug interaction, most likely it's either going to be 2D6 or CYP3A4 that you're going to run into if you were to do your homework this upcoming week. Okay, I guess we're done. I guess, do you have any questions before I let you guys go? Okay, I got the report for the test. I'm going to review this. If there's any givebacks or anything, I will send an announcement. If there's any questions that a lot of people seem to miss the concept on, I'll also put a clarification on there as well. So hopefully that'll be in the next day or two. I have like a 6-hour teaching block tomorrow, so it might be later on in the day. So forgive me if the video's a little late getting posted. Okay. All right, I'll see you guys next time.